Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
Sapna Patel.
Today, we're going to be thinking a little bit about the SITC, Society for Immunotherapy of Cancer, consensus definitions for resistance to immune checkpoint inhibitors. And actually, we're probably mainly going to focus on the paper from Journal of Immunotherapy of Cancer from 2023, where Harriet Kluger is the lead author, because I guess it's come up, hasn't it, a lot when we've been talking about interpreting original trials, this whole business about resistance and sensitivity. So we thought it was worthwhile spending a bit of time on that. So before we do that, icebreaker to you is, have you ever walked out of the cinema or theatre, I suppose, and why? And can you remember what you were watching? And if you've done it a lot, maybe one of the more memorable ones.
Have I ever walked out? Nothing comes to mind actually being seated and then leaving. I'm pretty, at least back in the day during my med school days and residency, I was pretty famous for being able to fall asleep in the theater. So not walking out, but sort of like being, I could just fall asleep and not tell you what happened. It happened in the last year or two. I was with my trainer and his wife, also a trainer, at our gym in Houston, at their gym. We went and saw the Superman movie. And it was one of the theaters where you can drink alcohol. So we were eating popcorn, drinking alcohol. And I probably lasted an hour. The seats were fully like lay flat seats. And I always bring a blanket from home because, let's just call it what it is, a nap. But I haven't left anything out of being turned off by it or uninterested. I'll just, at that point, take a nap. It did make me think, though, years ago with my friend Siobhan in Houston. This would have been before 2013 because I was in my old bungalow house. We got tickets to a Radiohead concert. And so it's the opposite of your question. Have I ever walked out? It's being so late to something that it basically ended. She had just gotten a dog, or was really heavily contemplating. So she wanted to come over, play with my Chewy. We were chatting about the dog, maybe about how does it work? How do you travel when going home? Blah, blah, blah.
Hang on. So when you say my Chewy, that's not a euphemism. That's your dog, right? Just so we're clear.
Yeah, that's my dog, Chewy. That's not a euphemism. Yes, we were playing with my Chewy, my woof woof Chewy. Anyway, so we got to talking. We were like, okay, concert starts at 8:30, so there'll be an opening act. Who's the opening act? Okay, they'll probably do 4 songs and then set change. Everything. Okay, we probably have 45 minutes to an hour, so let's get down there by 9:30, whatever. And so we take a Uber or whatever. We get downtown. We go to our seats, and there's some people in our seats. And so we said, oh, excuse me, I think you're in our seats. You're in our seats. And they literally said something like, you've missed the entire, what do you mean? Like, you can't possibly be showing up now for this. And we were kind of sort of like, mind your business. What's the big deal? We didn't want to see opening act, whatever. And then we are there. We probably caught 2 songs and the concert was over. Radiohead.
Do you know which songs they were?
Well, Creep was the last one they did, but no, I don't remember the next to last one. There's another one that I like. Or maybe Karma Police was the last one. Anyway, but it was pretty, like, the concert ended and we thought like, oh, is this just a set change? And then everybody started clearing out and we thought, oh, we really did miss the whole call. We really timed it very badly. Yeah. So we missed everything, but that's different from your question, which is.
Yeah, so I don't think I've told you this before, related Radiohead story. So they're from Oxford, and okay. when I was in Oxford doing clinical, 93 to 96, and then afterwards, I was there. I did one house job in Oxford. My girlfriend at the time, who was a Rhodes Scholar actually from South Africa, used to have a job.
Bosch. I remember that story.
That's right. She used to have a job working in a Thai restaurant, which was Radiohead's favourite Thai restaurant, which is called the Chiang Mai Kitchen in Oxford, and it was great. And she used to get like takeouts and stuff like that from there as part of the. And so quite often I'd go in there to like meet her after she was finishing work or something like that, and then Radiohead. This is before they were that famous as well. They'd just be sitting there all dressed in black, having their meal at Chiang Mai Kitchen. So
they're drunken noodles and their pad thai.
Yeah, I don't know if they've ever commented on that. I mean, I'm not an obsessive fan, so they must have done that somewhere in an interview, and I hope I'm not breaking any confidences there. Right, okay, so...
but have you walked out? Should we hear your walkout stories?
Yeah, well, the only one I can clearly remember is 12 Years a Slave, and I don't know when that came out, maybe 10 years ago, something like that, 15 even, and Emma, my wife, and I were watching, I think we were in Liverpool, visiting family, Emma's family, with, I think, my brother-in-law and sister-in-law, and so the four of us were there, evening showing. I guess we were tired, and kids were young probably, and so we probably wanted a relaxing evening in our defence. But we started watching 12 Years a Slave, and it just got to that horrible scene where, I don't know, probably the film's full of horrible scenes. I don't know, because we got to the first horrible scene, and we just looked at each other, and is this how we want to spend our evening? We walked out. And,
all four of you guys, or just you and Emma?
Just Emma and I. And then we went and got, some pasta and a bottle of red wine. And we had a nice evening.
As intended.
I'm sure it's an amazing film, but it was so traumatic. And it just didn't really feel like it was going to be the kind of evening we wanted to have. And we haven't tried to. I don't think we'd even try and watch it again, actually, because I'm not even sure I could get through that scene very easily. And I'm not criticising people that do and have. And maybe it's my duty to watch that as well. But it was horrible.
It would be one where after it would potentially be hard to have words.
Yeah.
After watching something like that, you just have to sort of sit.
Yeah. No, I'm not dismissing film or anything. It's just at least then we just couldn't face it.
Side note: Michael Fassbender, one of my favorites. One of my Hall Pass favorites.
Oh, maybe we could have him as a guest if we can think of something that is of wider interest.
We did a full nudity film one time.
Sorry?
Can we make that somehow make that medical?
Yeah. Why don't we let's put that on the sort of list of potential episodes.
Okay.
Anyway, so maybe just to chat about this paper. I suppose the background is it's important because, I mean, in my view, I've said this a million times before, it's probably the biggest challenge we now have in clinic in melanoma, which is resistance to checkpoint inhibitors. I guess I'm mainly thinking about cutaneous melanoma, obviously. So we see it all the time. You have the various different scenarios, I suppose. One is post-adjuvant. And then another one is metastatic, primary resistance, never any benefit from treatment. Secondary resistance, you get some benefit from treatment, and then the benefit from treatment wears off. So we all know what it is, everyone that's treating patients.
Right.
And I think the problem was that it wasn't really codified in a way that was useful, particularly for doing clinical trials and having definitions. I mean, the biology is heterogeneous in my view. We know that already. That's not really the issue here. I think the issue is about defining populations so that for clinical trials, in terms of trial entry, we have a sense of what those populations are. And also when defining output of trials, we can gauge what we think that means depending on the characteristics of the patients going in. And I haven't said this to you before, but my other thought was I immediately thought of platinum resistance and sensitivity in ovarian cancer. And I guess in the early days of platinum and ovarian cancer, a lot of time and effort. Actually, Martin did a lot of this. Martin Gore was defining all of this. And I think for ovarian cancer, I remember when I was training, this obviously was the main issue you were thinking about with patients. What's their platinum sensitivity, yeah, and then how do you think about subsequent lines of treatment and so on and so forth. So those are my background reflections, I guess.
So as you said, there's primary resistance, there's secondary resistance, but there's a key part here, which is drug exposure required. So in order to be called secondary resistance, you need a few things. You need initial benefit to therapy. So that's a CR/PR, or stable disease lasting 6 months, right? The stable disease has to last more than 6 months, not necessarily the CR or PR, but the drug exposure has to be 6 months. So then what do we call somebody with drug exposure of 4 months who had a partial response but lost it?
So they wouldn't fit this definition
right
very easily, would they? So then, I mean, you were just talking about table 2, which summarizes it nicely. This is the Harriet Kluger lead author paper. And just to sort of, I suppose, bookend that, I'll comment on it. For primary resistance, it says a minimum of 2 cycles of treatment, and they're talking about combinations here, just to be clear, of both drugs, brackets 6 to 12 weeks, or actually parentheses, 6 to 12 weeks if we're being really picky. Do you know about that distinction?
Say that one more time.
Brackets versus parentheses.
Please illuminate.
Parentheses are curly, brackets are square. So yeah, it's a common mistake. That, look it up afterwards. Honestly, I'm not making that up.
Yeah, because anyway. we would have said the opposite in the US. Parentheses are rounded, brackets are curly.
Wow,
curly brackets.
That is an amazing discovery. But yeah, so in British English, that's the distinction, I believe. I think I'm right about that. Anyway, so primary resistance, you need to have had a minimum of 2 cycles of treatment, which generally will end up being 6 to 12 weeks. And then the best response to that is progressive disease or stable disease lasting less than 6 months, with the requirement for doing a confirmatory scan at least 4 weeks after PD if the patient is stable. So I suppose you're making the point that there's something in the middle.
Yeah, I mean, as there always is. What happens if you have more than 2 cycles exposure or 2 doses exposure to ICI, but not 6 months worth of exposure? What are we calling that? You know, we all have had this scenario where somebody gets 2 doses of ICI, gets toxicity if it's combination therapy in the advanced setting, stops. How are we characterizing their benefit, if there was one or if there wasn't one? And then same with adjuvant therapy, they might have taken 4 months of adjuvant therapy, stopped for whatever reason. Are they primary resistant, or they don't meet the drug exposure to be secondary? And so like there is still a gray area despite this really good effort. And I guess my question really goes into how we're developing drugs in this PD-1 experienced setting. So now we have lots of small biotechs. We've talked on the podcast about many interesting signal in phase 1. Maybe you and I can banter back and forth about this. What do we think the bar is for primary resistance, response rate, or PFS?
Yeah, I would go for response rate. I think I've said this before. I think PFS is by definition potentially more difficult to interpret, certainly in non-randomized trials, because you've got the natural history of the disease to take into account, which isn't controlled for. A response is a perturbation, to use that word maybe, in the natural history of the disease by definition, okay? Because you've got tumor that is shrinking, yes. hopefully because of your intervention. But that's another issue just to think about. So for me, primary resistance to checkpoint inhibition in melanoma, I would be happy probably with a response rate of at least 15 or 20%, I think, with median response duration, I think, of at least 6 months. So that would be my kind of bar, I think, for an interesting signal. I'm not saying it's right, but that's what I'm thinking.
So, because we've done an episode on PD-1 resistance, I don't know if at this point we've published it, but potentially by the time we publish this episode, we will have published that, where we talked about the Dan Olson, the Inez Perez de Silva non-randomized data, and then the S1616 randomized SWOG data. At least for those, it's pretty consistent, and the S1616 was for primary resistant PD-1 patients. So as per the SITC definition, that would be at least 2 exposures to checkpoint, 2 consecutive exposures, and progressive disease or stable disease lasting 6 months. Okay. So the single agent response rate there is about 10%, and it's considered the null hypothesis for this. So kind of uninteresting just to get 10%. So I think your 15% bar is right. But we have seen the signal as high as 30% because it's something like 27% in S1616 and right about there in the Dan Olson, Lotus, Ipi, Pembro, etc. So I think 30% is where the bar is for primary resistance. If you're developing a drug, you know, TIL, lifileucel, if you will, was 4th line therapy, median 4th line, and was still getting 35% response rate. So I think that's where we might need to be there. Now, more complicated is secondary resistance, because you say something that is incredibly fair. I don't know how many drug companies are listening, that in the secondary resistance, these are patients who've had a benefit. It's the duration of drug exposure was at least 6 months. So they've had stability of their tumor burden or a true perturbation, as you described it. And now you're going to do something more. And a lot of times it's with a PD-1 backbone continuing, and you add something to it. And then what is it that you say about that response rate that we need to be careful of when we see it for that population?
The fact of residual sensitivity to anti-PD-1 or anti-PD-L1, for the sake of argument, I would have thought, I think we all know in those kinds of patients that if you'd given the patient anti-PD-1 or anti-PD-L1, again, let's just say monotherapy for the sake of discussion, it doesn't need to be though, there will be some activity that's in there. And so then how much is that activity? Well, difficult to know. And it will depend a lot on the patient characteristics, how long have they been off treatment? So in other words, if you've stopped the treatment after a period of time, some of those people are still going to have drug on board certainly at 3 months and maybe even to some extent at 6 months. So that's important. If you've got people who, let's say, definitely over a year since their last treatment, I think you can be confident there's probably not much drug on board, but then that doesn't mean there isn't some biological effect
sensitivity,
of the drug on board. So all I'm saying is that let's call these partially sensitive by my definition, if you want to call it that. I think a lot of those patients, you're going to be seeing a 10% or greater level of benefit based on response rate if you were to just give them monotherapy again with anti-PD-1 or anti-PD-L1.
So then for that population, going on to their next line, they are potentially PD-1 still sensitive. I guess I have 2 things to say. We should really be careful about the gap from prior PD-1. So is that gap less than 3 months where there's still potentially drug on board, or is it greater than? Do we want these patients coming directly off of that therapy onto this whatever next line therapy is, or do we want a gap? And the second thing I would say is, do you then think, no right answer here, no wrong answer, do you then surmise that the ORR for a secondary resistant PD-1 patient should be higher, lower, or the same?
Higher, definitely higher, I think, for the reasons that I've said already. But getting back to my comment about primary resistance as well, and I'm saying, 15, 20%, something like that. I think maybe I'm deliberately a bit conservative about that, because I'm sort of thinking, let's say you're doing a trial with a new modality of treatment, so it's not a checkpoint inhibitor backbone. For me, that level of signal is interesting. And what I'm saying in that primary resistance setting is that if you've got a signal that's looking like that, that is actually something I want to know more about. I would not throw that away with a new therapy in that situation, because we're talking about looking for signals here, aren't we?
Agree that that's a signal. Something in the 15% response rate, primary resistance, is a signal post PD-1. Is it enough to get you regulatory approval and a phase 3? I don't know.
No,
I doubt.
I think, that comment from me is about looking for a signal. But at the end of the day, not always, but it's likely you may have to do a randomized trial and then benchmark against something. That's another subject in its own right, what the control arm is and so on and so forth.
And this is where I just want to put a word of caution, is that sometimes what we're seeing signals in this space that are in the 25-30%, but they haven't carefully curated or defined the population that entered. It's just a PD-1 experienced population. So that could be PD-1 experience in the adjuvant setting, and you finished your adjuvant course and sometime later your melanoma comes back. Technically, that's a secondary resistance, if you were. I mean, I don't even know where we're placing that, although this paper has an adjuvant exposure table. So that PD-1 experience in the adjuvant setting is not the same thing as taking it and being primary or secondary resistant. So then whatever signal that, a company might be seeing in their phase 1 to then be very careful about going straight to a phase 3, do some phase 2, but clean up the population. Go looking for that signal in this population or this population or this. And, I, like you, would be happy to think this through with pharma as far as specimen samples and then looking for a signal. Which one of these do we think is actually happening? Are you reviving an old effect? Are you bringing in effector T cells where they weren't there before? So helping with a primary resistance issue, et cetera, et cetera. Anyway, yeah.
So I was just going to say, I think that goes back yet again to the importance of doing randomized phase 2 trials. Correlative biology, I think, goes without saying. And then in terms of trial design, do you then need to do a separate phase 3, or can you use the randomized phase 2 as a starting point for a phase 3? I mean, that would be, to me, a smart way to do it, I think.
And you could argue Relativity 047 was sort of done that way. It was a phase 2/3 with an endpoint that they used for phase 2 as go, no go. Once they hit it, they picked a clean endpoint for phase 3 that the phase 2 portion of patients could still be evaluated for.
Yeah. Just to say something about control arms and randomized trials as well, though. So this whole business about doing randomized trials sort of, to some extent assumes that there is going to be a satisfactory control arm. And they actually say this in the SITC paper. It's quite an important point. In other words, let's say you were to give single agent anti-PD-1, again, for the sake of discussion, what is the expectation of efficacy in the control arm? Because again, ethically, if you don't have any significant expectation of efficacy in the control arm, then there's a big question mark. And then to broaden that out, you could then talk about cytotoxic chemotherapy as a control arm.
Well, and we've had this conversation with companies that are in this space. At that point, maybe arguably you could just say investigator's choice, because there is A, no real front runner, B, no one therapy is going to do necessarily so much better than another. So just let the investigators pick whatever they would do for control, minus perhaps local therapy, because oligometastatic disease, oligoprogressive disease, localized therapy does have a role for that kind of stuff. So I think the caveat being whatever systemic therapy you might do.
Yeah, and I think to your point as well, then I think you then have the investigators with the patient in front of them, and they're thinking about patient selection for the trial.
Yeah.
And then that means that they have to consider what the control arm is and whether they, in their own minds, knowing the patient really well, can have that conversation with the patient or not. And so then one would hope that would mean that localized therapies, those kinds of patients actually weren't going in the first place, because that's just not going to help, I don't think.
Do you prefer a trial that says investigator's choice of this menu of options? Or do you prefer a trial that says investigator's choice is the control, whatever you can come up with systemic?
I somewhat prefer a menu, if I'm honest. I just think it's cleaner, for want of a better word. I'm actually thinking about the Immunocore trial as well, which we know quite well.
I have answered the Immunocore one.
Tebentafast.
Okay.
First line. Investigate. You and I know that one quite well. And you could say, well, what if it's not available? So I think that's part of the feasibility process, that you go and you talk to people inevitably, or mainly globally, and you say, okay, what have you got access to? And then you actually have discussions with investigators about what's available and what they are comfortable with as a control arm. Whereas I think if it's completely open, then it's sort of kind of messy, I think. And so I think, I don't know if it's a strong view, but I think I prefer that.
I mean, it's messy clean, as we just said, if all the controls are roughly missing the mark to the same degree. I mean, you bring up uveal, so I feel obligated to say the issue with the TEBI study at some sites, certainly in the US, is they didn't feel comfortable with the control menu of options, pembro, dacarbazine, and temozolomide maybe, just really felt uninteresting, and they didn't feel they could comfortably randomized. In fact, as you and I know, there was some study conduct issues with German sites that patients were getting randomized to the control and then getting taken off study, which has an OS endpoint, then you're never going to read out. And in fact, this happened with Hepzato, with the Delcath treatment. It was randomized to best supportive care.
Do you mean Heptazo?
You mean Heptazo. I'm calling it by its official name, Hepzato. So the control arm there, basically it was best alternative care. I think I said best supportive, but it was best alternative care. And it was just so uninteresting that people were dropping out. So
yeah,
and that might have been in the absence of a menu. The TEBI study had a menu. So there's probably no perfect way to do it, but your point is.
But listen, I think there's a load of different trade-offs here. That's the reality of this. It's not perfect, clearly. Yeah. And actually, it's not just going to be about the sponsor and the clinicians. There's regulatory considerations. There's all sorts. And, to be honest, at the end of the day, the sponsor needs to come up with a study that's going to do the job, I think, taking into account all of these different perspectives. But you're not going to keep everybody happy.
Yeah.
I think that's the reality.
Can I put you on the spot to go through table 3 and table 4, and then we can wrap?
Yeah. So table 3, adjuvant setting. Primary resistance in the adjuvant setting, less than or equal to 12 weeks after finishing therapy or recurrence on therapy. And undeterminable is the other category, which is greater than 12 weeks. So basically, they're using a 3-month cutoff there. So
but to be clear, James, that also means less than or 12 weeks. Okay, maybe I'm overthinking it. I was thinking, like, what happens when you discontinue your therapy due to tox? But yes, then less than or 12 weeks from therapy discontinuation, if you have a recurrence, doesn't matter that you stopped it for tox. They're saying as long as you've had 2 doses under your belt, they're going to call that primary resistance.
I suspect they spend a lot of time, hammering this stuff out. And do you know what I like? I'm all for simplicity anyway, and I think that this is simple. It's clear, and for it to be usable and workable, I think that's the right balance.
Figure 1 gets a little complicated, but I get the point of it. How about table 4?
Yeah, so this is called resistance scenarios after halting therapy in their metastatic setting. So here they're making the distinction between induction therapy, so that might be ipi-nivo, say in melanoma or renal cancer for that matter, when you have the 2 drugs together as induction, and then versus continuous. An example of continuous would be nivo-rela, actually, where you're getting both drugs the whole time. And I think there's 1 or 2, I think it's in maybe mesothelioma with ipi-nivo, where your ipi is continuously given 1 milligram per kilogram every 6 weeks, as opposed to what we're used to in melanoma.
227.
Yeah. So just for the record, I guess. Anyway, so take into account those 2 scenarios. One is the continuous part of the treatment. One is the induction part of the treatment.
Again, easy with the hand gestures here. You did this at ESMO too.
Yeah, and I was doing it as well in the visit last week with the Princess of Wales. There was like a picture, and I just caught myself. I don't know. Maybe I'd need to cut down, or maybe that's another New Year's resolution. Less hand. It's because I'm enthusiastic, though. I don't think it's a negative. I don't think it's a negative. Anyway, so you've got these 2 scenarios. That's the first thing, and then the second thing is the second column on the table is timing of tumor regrowth. That's what they're calling that. And so then that can be either less or more than 12 weeks after the last dose of treatment, so similar sort of cutoff. And then the final column of the table, the third column, is called resistance phenotype. So that is either primary or secondary resistance to the combination in the continuous setting. And then in the induction setting, it can be either primary resistance to the drug that was continued, and then the final one, which is greater than 12 weeks after the last dose in the induction setting, it says must be assessed based on re-challenge. So I think the point for that very final one is that in that situation, actually, there probably is going to be some potential sensitivity to rechallenge. And if you're thinking about ipi-nivo and melanoma now, we all know in practice, again, and we talked about this before, since the days of ipi-mono, can I say that these patients who get ipi-mono, they get some benefit, wears off. We're not doing this so much anymore, but we know that there's going to be some residual sensitivity there to ipi rechallenge.
So can I ask you in table 4, the second line, continuous administration, let's say of combination, because that's what this really means, more than 12 weeks after the last dose, can we really call that secondary resistance? Because wouldn't you re-challenge that group as well and then assess response or resistance based on re-challenge? What we're saying there is it's more than 12 weeks after the last dose.
Yeah, I mean, they've had to come up with a number here. If you and I take your point, and I think I would certainly think about that in clinical practice. But again, I'd come back to simplicity and pragmatism here.
But that's my point. Why wouldn't they make it simple to match the induction greater than 12 weeks? Anything greater than 12 weeks after the last dose, you've walked away from the therapy and now we're putting it back in. And much to that earlier point, is there not some residual sensitivity? Because they're recurring right at the 4 half-life mark of the drug being washed out. Are we sure that's secondary resistance? Anyway.
No, I agree with you. I think it is likely in that group of patients there will be some residual sensitivity there, and that's what I would be thinking about in the clinic, I think.
So for simplicity's sake, I could have collapsed this into a 2-line table. Whether it's continuous or induction dosing, it's less than or 12 weeks or greater than 12 weeks after the last dose, and it's primary resistance, and then it's like indeterminable based on re-challenge is what I would say, I guess. Or, obviously tumor biopsies as the meat of the paper.
So we would need to get the transcript, I think, of the meeting, because I suspect this was discussed.
Yeah.
And maybe just to finish, we'll just say something about the different groups here, the working groups, which are just listed out right at the end of this paper. So Harriet Kluger chaired the checkpoint inhibitor combinations working group, and then there's another group for checkpoint inhibitors and chemo, chaired by Ryan Sullivan, and then finally checkpoint inhibitors. It's called tumor-targeted and anti-angiogenic therapy, and then Hussein Taubi was the chair of the last one, and the names are in there. So there's quite a lot of FDA people and quite a fair amount of people from industry as well as academics and clinicians. So anyway, what I think about this is it's great. I think it's important. It's never going to be perfect, but I think kudos to everybody involved actually establishing these definitions. We really needed them.
Great framework for us to be able to lay our data on top of. So
and make podcasts about.
Yeah. All right. Thank you. Thanks.
Thank you. Take care.